Yeah, life.
Good evening, everyone. I, Dr. Aarti Heda, welcome you all to IOC 2024, 4th International Ophthalmic Conclave, hosted by All India Ophthalmological Society. I'm the session host for this retina imaging session, and I'm proud to say that the 3-day long conference, virtual conference, is coming to end, and we are in our last session. And as we say, we have saved the best for the end. So to moderate this session, we have with us Dr. Jay Chablani. He's professor of ophthalmology at University of Pittsburgh School of Medicine. He's trained in medical retina and vitreoretinal surgery. So without taking more of your time, I'll hand over the session to Dr. Jay.
Thanks, Aarti. Thank you so much for the kind invitation. And I think it is really a pleasure and honor to organize this session. And I am lucky to have Vas with me here, who is chairing the session, who is a world expert in imaging. Along with we have imaging experts from around the world. I think Vas is up in the early morning, and we have people from almost every time zone. So with me, we have Dr. Srinivas Sadda, we call him Vas. He is from Los Angeles, and then we have Dr. Giuseppe Kurukas from Milan, and we have Stella from Italy, and we will also have Dr. Bhavan Kule's virtual talk, which has been recorded. And then we have a few of our friends from India, Dr. Ramesh Venkatesh from Narayana Nethralaya, Bangalore. Then we have Dr. George Manayath from Arvind Coimbatore, and our dear friend Unni Nair from Chaitanya Hospital, Trivandrum. And the best talk is going to come from my dear friend Rosa, who is hailing from Spain. Welcome you all, and thank you so much for being part of this session, and we look forward for interesting talks. Vas, do you want to say a few words about the session and get started with your talk?
Yes, thanks very much, Jay, and again, very much looking forward to this session on retinal imaging 2024, titled Vivid Vistas. And I think that this is a great update session. I think that I thank Jay for organizing and arranging this this array of talks and recruiting, as he said, really an all-star panel, world expert speakers. And so I think, one of the things I would say with retinal imaging, it's a very exciting field, but because we probably could have an update meeting every month, because I think that's the pace of innovation in this field. So I'm excited to hear these presentations. So welcome to you all. I also wanted to give a special thanks to Dr. George and Dr. Uni. They're going to be helping us with some of the discussion as well. So look forward to your questions and comments throughout the session. So with that, Jay, I'll turn it back over to you, because I know you're going to introduce our speakers as we go along.
Yes, I think the first talk is by you, Vas. You'll be talking on imaging updates in geographic atrophy.
Okay, fabulous. So let me share my screen, and I will proceed. So hopefully that has shown up okay. And okay, very good. So I'm going to talk about imaging atrophy and some of the current thoughts about this. These are my disclosures. And so really the core of my presentation is thinking about the diagnostic techniques that are helpful to us in assessing atrophy right now in January 2024. And several years ago, we had actually compiled a list of imaging modalities. And again, this print on this slide is very small. It's not intended to be read. Just to say that every technology has its advantages and disadvantages, and that was sort of the purpose of that review. And I want to start first, even though you might say, well, how can I be talking about this in 2024? This can't be an update. But I think it's still worth mentioning something about color photography. This was obviously the gold standard for diagnosis for many decades. We have a definition of atrophy on color imaging with this tripart definition of sharply demarcated borders of areas of depigmentation with increased visibility of choroidal vessels. And of course, we've recognized over the years that color photography has substantial limitations. Here in these examples, I think everyone here can appreciate, yeah, there seems to be an atrophy there, But if I asked you to precisely determine its borders, in the absence of excellent stereopsis, it can be really quite difficult. And that's, of course, the challenge with standard flash color imaging, is the contrast can be an issue. And this is where there's obviously been innovation over the last several years in the form of confocal color imaging. And of course, that can happen with confocal white light, as it happens with the AIDEN system, or it can, and you can, it's just an example showing, I think it's pretty obvious that it's much easier to appreciate the atrophy in the confocal image. Here's just more examples of that. And in fact, we've actually demonstrated this, the Reading Center, in a systematic fashion, where we demonstrated a very high level of repeatability for assessing atrophy using confocal color, which was at least as good as that of fundus autofluorescence. So just highlights that just when you thought that color imaging was dead, actually, confocal imaging actually, I think, makes a big difference. Now, of course, when you're using confocal imaging, you're not limited to just using white light. You can use an array of lasers. For example, Mirante uses their device using separate red, green, and blue lasers. And that, of course, can yield very good imaging of atrophy. Again, I think the confocality is one of the biggest benefits. Of course, there's no reason, once you're using individual lasers, that you should stop at red, green, and blue. You can replace, for example, the red laser with an infrared laser. And that, of course, will give you even deeper penetration. And that can also allow you to see the atrophy quite well, as in this example. And of course, just one other comment about with regards to infrared imaging, we can actually just take the infrared alone, right? So we can use the various different wavelengths, but if we just use infrared reflectance imaging alone, we had demonstrated that actually can be used to measure the atrophy, and it shows a very nice correlation and good repeatability compared to fundus autofluorescence imaging. And you might say, well, why do I care? Why would I ever do that? Well, sometimes you may have historical data sets where you don't have maybe autofluorescence, and you don't have dense volume OCT, and I'll talk about OCT in a moment. And this, but of course, you'll always have the companion IR image, and in that case, you can do this type of assessment. So let me talk next about a couple of other approaches in fundus autofluorescence and OCT. Fundus autofluorescence, of course, offers the benefit of tremendous contrast. Going back to the previous case, again, everyone can appreciate how well and easy it is to delineate the regions of atrophy. It's why this is the key technology that's used in current clinical trials to measure the progression of atrophy, and it's been used as an important endpoint. A limitation of standard blue light autofluorescence, though, is it can be quite uncomfortable. If you've had yourself imaged using this technology, I think you're well aware of that. And then the people have raised the question, even though these technologies have been assessed for safety in normal individuals, and we have ANSI standards, what about for a patient who has an inherited retinal degeneration or even an atrophic macular disease? Is the blue light exposure toxic? I mean, there's been some controversy about this point. And this is where, of course, we have other options. We have green laser wavelengths available on many devices, Spectralis and the Optos, other devices as well, and NIDEC device. And Max Fau and the group in Bonn had done this nice published this nice paper where they demonstrated that green autofluorescence was equally good as blue, if not better, for doing this assessment. And so another question that's come up is that, what about with ultra wide field imaging? Sometimes, that's the main imaging technology a particular center may be using. Can we use this in clinical trials? So one of the questions, and again, we've been very interested in the concept of using ultra wide field autofluorescence imaging for many years and have studied this in the setting of AMD. But one of the questions that's come up is, does it have sufficient resolution for doing macular work? And it's just to show that we have even blue autofluorescence now in the ultra wide field imaging platform, in addition to red, green, blue imaging. And just show a couple of examples of GA. But again, is it going to be sufficient resolution when you're using unaveraged fundus autofluorescence images? And we've done a study now. This is something I presented at the recent EURETINA meeting, where we compared delineating atrophy on ultra wide field versus standard posterior pole imaging, to demonstrate that you actually can do this quite repeatably. Although I will say, because of magnification and other issues, the absolute values do differ. But again, the repeatability for amongst graders is very high. Okay, so lastly, I'll talk about OCT. And again, obviously, OCT is the most comfortable imaging technology, I would say, and atrophy is well seen. We see it as these areas of hyper transmission, which when we do a projection image, they appear as brighter regions. And we've shown that, this is data from the Mahalo study, that there's a nice correlation between fundus autofluorescence and OCT-based assessments of atrophy in terms of the area. I will say just because two things are highly correlated doesn't mean they're measuring the same thing. And in fact, we know that they're not exactly the same, but certainly the correlation is very strong. One of the challenges, though, is every bright spot that you see on the OCT on-FUS image, is it atrophy? Here you can see an example where you see hypertransmission, but maybe there's a few little RPE cells remaining there. Maybe this is incipient atrophy of some kind, or nascent atrophy. What's the threshold? And that was the rationale behind the CAM group that came up with this definition of atrophy on OCT and said that you had to have hypertransmission, certainly, and they said it had to be at least 250 microns. You might say, why did they come up with 250 microns? It's because the reading centers who were part of the CAM group said, we're not sure if we can do this reliably if it's smaller than that. In addition, you have to have a loss of the RPE overlying the hypertransmission. As you can see here, you can see the step off in Bruch's membrane in the bare, where the RPE is absent in bare Bruch's membrane, and you have to have evidence of overlying RPE degeneration. And this has been shown to be reproducible for assessing the area, at least in several different reading centers. Now, some features, though, can be a challenge, like assessing the RP disturbance, especially when you're trying to assess Aurora. Not easy. We've shown that there can be some limitations in the repeatability of that. And this is where, and I don't want to take away from Rosa, because I know Rosa will probably talk about high-res OCT in her presentation, but this is where high-res OCT, a higher axial resolution, gives us tremendous visualization of Bruch's membrane in a very consistent way. Here you can see the residual RP cells on Bruch's membrane. In this case, it's very easy to identify the termination. We've shown in just a recent paper just came out in press a significantly higher repeatability for assessing with high-res OCT. Of course, going forward in the future, we'll have deep learning approaches for assessing atrophy. This is just skipping forward to some nice work from Phil Rosenfeld and Ricky Wong in doing this kind of assessment. And of course, with deep learning, we'll even be able to predict the growth of atrophy over time. I just wanted to finish with this one last thought that I just wanted to highlight, that just measuring the area of atrophy alone may not be sufficient for assessing the efficacy of therapies. We know that atrophy, for example, grows at a different rate in different directions. And we think there's a real value in looking at the growth rate of atrophy as a linear kind of assessment. This is just an example. This is actually a paper we published in Ophthalmology Retina a few years ago of a stem cell therapy that apparently failed because it didn't seem to slow atrophy. But we actually showed in this paper that the atrophy didn't really grow towards where the stem cell graft was placed, but grew in every other direction. So that was missed on the overall assessment. So it just shows that directional kinetics can actually make a difference. So to summarize, in a very rapid fashion, I tried to highlight that, in terms of what we currently use, progression of GA area is the main important endpoint. We're in this era of GA therapeutics, so I think we need to have this ability to image atrophy. Actually, I think is topical. That's why we wanted to have this in this session. I talked about flash color being the past, blue the present, but really we have a variety of other technologies, which I think, including OCT, which I think represent the future. Thank you, and I will stop there for questions.
Thank you so much, Vas. Fantastic talk, as always. I had a question. Where do you keep OCT angio in the assessment of GA or the nascent GA? How do you trust the choriocapillary scan while looking at the GA?
Yeah, so thanks, Jay. So I didn't include it in the presentation mainly because it really, we use it a lot because it's as a research tool because we're very interested in the role of the choriocapillaris and progression of the disease. Don't really use it really at all as a diagnostic tool or a tracking tool to follow atrophy. So that's why I didn't talk about it here. But absolutely, in terms of its reliability, your ability to visualize the choriocapillaris consistently, aside from making sure there's obviously not blocking material, things of that sort, which can be managed to some extent, is really a matter of having accurate Bruch's membrane segmentation. And so some of the manufacturers have done a pretty good job of that. Others struggle a bit, and then you can have some challenges. but the accuracy of Brooks membrane segmentation is really critical. That's where I think, and again, as I said, I don't want to take away from Rosa's talk because I'm sure she's going to talk about high-res OCT. But I will say that is a big advantage. I used to be a great, I'll call it a poo-pooer of going higher resolution OCT. I don't know what's the actual clinical value, but the real clinical, and I have to say that I've changed my mind about it a lot because of the Brooks membrane visualization. I think that's going to only help us with Brooks membrane segmentation. That will help in choriocapillaris assessment.
Great. Thank you so much. Any questions from any of the panel?
Yeah, I just wanted to ask a question. It's always a pleasure listening to you, Vas. I just want to know how good are we now at assessing the edge progression with OCT nowadays? But there's a lot of different, indices, a lot of different things, junctional effects of the outer retina, circularity index, the convex cell. How good are we at assessing which edge of the GA is likely to progress and with the OCT?
So Uni, that's a fantastic question and a very timely one because of some of the recent discussions at the regulator level of how new therapies are going to be assessed. What I showed, and again, I had to cover a lot, so I went very fast, was I focused on looking at using the hypertransmission on the en face image and to delineate areas of atrophy. And that actually can perform quite well, as several people have shown. But to your point, one thing we've recognized in GA lesions, and one of the advantages of OCT is you see it in multiple layers, right? Hypertransmission you can view as one layer in this OCT slab, but what about looking at the EZ, for example? And many of you may know that a few of the biopharma companies have shown that, like I'll point out one in particular for alimipritide, for example, they showed in particular a benefit of slowing progression of EZ loss, right? And EZ loss is much more challenging because I think the border there is not as sharp. But they did show a benefit, and recently the FDA gave guidance that they will accept the EZ change as an endpoint. And then there's many people who believe that that's a preferred endpoint compared to the current autofluorescence standard, in part because of some of the lack of correlation in some cases between the autofluorescence and some of the other outcome measures in the recent therapies. So that's where I think it's still a little bit of a challenge in terms of sharp border. People are using other approaches, and there are obviously deep learning approaches to be able to quantify the EZ. But I like your question because the point is with OCT, you can define the GA lesion in multiple ways and not necessarily just on the hypertransmission, but on the EZ, even ELM. Christine Curcio, for example, histologically, she says that the edge of GA should be defined by the ELM descent. And so the ELM is actually what defines the true border. But I would challenge any of us to do reliable ELM segmentation in every case. So it's great that that's the border, but boy, that's going to be hard to use to measure.
Jay, if I can ask a quick question.
Last.
Dr. Vas, always a pleasure listening to you. Here, I heard you about the imaging infrared versus blue versus green, because we are limited. We have all of us listening to you have blue autofluorescence. Most of it Heidelberg is what we are used to for assessing the progression along with OCT. When the patient in a clinical setting. So we have near infrared and infrared, but then what would be your choice if given along with OCT, maybe a high resolution OCT, but for the on-face part of it, what would be your choice, because you have experience with all these modes of imaging?
So it's a good question. So I mean, the simplest, obviously, to get is to do the standard posterior pole blue light autofluorescence, right? That's the tried and true, simplest. It's very easy. It's easy to explain to patients because they see a dark area. That's where they can't see. Having said that, as I pointed out, I think that OCT is the most comfortable, though, and it's what we use now that we have these therapeutics. At least in the U.S., they're available. I mean, I won't say that they're wide. The use is expanding, I guess I'll put it that way. I think in our practice, at least, we primarily use OCT, in part because a lot of our historical data is built on OCT, and I personally wouldn't consider treating a patient unless I had previous historical data, so that I know what the rate of progression is, so I can get some sense of, is the treatment working or not. And so for that reason, because most of our historical data is OCT, because we don't routinely do autofluorescence, at least, I do it periodically, but I don't get it regularly like OCT. That's why I tend to prefer OCT for that reason. But in terms of you want something simple, easy, there's clearly good tools to assess it. It's autofluorescence. And I would say the deep learning tools for assessing atrophy and autofluorescence, which ours and many groups have published now, are nearly perfect, I have to tell you. I mean, I've lost equipoise on it. They perform very well for atrophy segmentation.
And for the drusen subtypes also, have you found any difference in these, SDD versus or subtypes? Is there any other than OCT? Do you find any of these green or blue or in infrared or any of these imaging specifically good for?
So for SDD, no question, blue autofluorescence and IR, much better for visualization. That's been well established. For regular drusen, I don't really use those methods to see the regular drusen. I think actually, if you want to see regular drusen, other wavelengths, even color image, visible light color imaging, and OCT obviously would be much better tools.
Thank you.
All right, thank you so much.
Jay, we need to move on.
Yes, thank you so much.
We have such an all-star panel that we need to hear their presentations.
And all-star questions as well. So
yes.
We will move on. Thank you so much, Vaz. And we will move on with Giuseppe's talk. Giuseppe, please take it away.
Thank you, Jay, Vaz, and AIOS for inviting me. Let me share my slide. I think now you can see my slide. So imaging and updates on imaging in wet exudative AMD. And this is my first slide, but in a sense is also an important take-home message for my talk today. That is this editorial from Solomon Eve Cohen a few years ago. So at the very beginning of clinical practice with OCTA combined with structural OCT, was the first to suggest that we can do we can manage most of our patients just with a combination of structural and angiographic OCT, and that we need dye angiography only for difficult cases in which we cannot optimize the management with only these two non-invasive tools. So no doubt that OCT with structural and angiographic information is extremely important for everyday managing of patients with wet AMD. And this is the classification that was revised by Bailey-Freund and originally proposed by Gas, that classified neovascularization on the basis of their localization with respect to the RPE. So we have type 1 sub-RPE, type 2 sub-retinal neovascularization. But since Bailey-Freund introduced type 3 neovascularization in 2008, a consensus that is the Conan suggested not to call in wet AMD neovascularization is choroidal neovascularization, but rather macular neovascularization. This is because type 3 neovascularization are in most cases, probably in all cases, originating from the retina. And this slide, you can see a correspondence between histological cartoons or histological information, structural OCT information, and FA. So we don't see type 1 MNV that are sub-RPE MNVs with FA. That's why they were originally called occult. But indeed, with ICG what is occult on FA is visible. So there's no reason to call them occult, and this is the reason why we prefer to call it type 1. Then we have type 1 MNVs that are not exudative, and this paper that is now has been published more than 10 years ago. My group and I suggested the term quiescent CNV for those neovascularization that have been never treated and that show the absence of exudation and were well visible on ICG. At the time, we had no CT angiography. So on ICG as a late plaque, and on structural CT as a flat, irregular, with major horizontal axis pigment epithelium detachment. Now we know that this quiescent MNVs, while they are clinically quiescent because they have no exudation, so no fluid, indeed they have, at least some of them, they are biological active, and this because over time they may enlarge even if without exudation. And this paper coming from the lecture, the Young Investigator lecture of the Micro Society, my group and I suggested some features that may somehow predict short-term activation for quiescent and non-exudative MNVs. And this information they have been later on expanded in this progress paper. That is a collaborative paper. And we looked in this paper in two major forms characterizing exudative AMD, that is type 1 and type 3 MNVs. Let's have a look at the type 1 MNV. That is by far the most frequent type of MNVs in AMD. So this is the baseline for this patient. So we have a flat, irregular RPE, small RPE elevation, and to this corresponds on OCT angiography a small MNV, type 1 MNV. So let's follow this patient over time without treatment, and we can see that as soon as at 3 months, this MNV showed an impressive growth both in height and in thickness of the neovascularization as well as the area of the neovascularization. And indeed, just 1 month later, this neovascularization presented some exudation. So this is a form of non-exudative MNV that was originally reported by Phil Roosevelt as subclinical MNV. That is a kind of initial step in the neovascularization formation that then will develop exudation that is much stimulated by VGF. And so this is a kind of angiogenesis for this kind of type 1 non-exudative MNV. Let's have a look at another case. This is a case with a similar flat irregular with major axis pigment epithelium detachment. And we can nicely see that on ICG there's a late plaque. So at that time we had no CT angiography, so we have to refer on ICG for the presence of a non-exudative type 1. But this patient was followed for many years, and this is at 1 year, then 2 years, and then CT angiography came up. So we were able to follow this patient with a combination of structural and OCT angiography, and 3 years and 4 years, no exudation, 5 years, 6 years. You can see that the size and the overall shape and the vascular density for this non-exudative type MNVs, type 1 MNVs is more or less the same. So no change over time. And I can tell you that this patient was then followed for more than 12 years without exudation. So this is a different form than the one that we have just seen, which probably the neovascularization is characterized more by an arteriogenesis. And this is a real quiescent MNV with little or no VGF dependence. So we have 2 different forms of a non-exudative MNV, one that is just an initial step in type 1 MNV development that will soon develop exudation, and one that is much more quiescent. One is much more driven by VEGF, and the other one is much more characterized by other factors that are then causing arteriogenesis. So the other form that we have in quite frequently, we can detect in neovascular exudative MNV, AMD as type 3 MNV. So we have, Iannuzzi, Larry proposed 3 different types, but now we know that the majority of them is originating in the retina and then progressing towards the choroid. And more than 10 years ago, we realized that the angiogenesis for initial type 3 MNV could be localized at the level of the deep capillary plexus, the outer plexiform layer, and in strict contact very soon with the RP. So let's have a look at what is non-exudative type 3 MNV. So this is a case with exudation. I will go very quickly because I have no more time. So this is the exudative type 3, very early detected because the exudation is very little. If we go back, we can see something that is very similar to the paper that we published more than 10 years ago. So this hyperreflectivity at the level of the deep capillary plexus and the outer plexiform layer, is this just pigment? Well, with the help of OCT angiography, now we know that this is not just pigment. This is already a non-exudative type 3 MNV because we can detect flow inside. So this is what we define as nascent type 3 MNV that I'm showing here for you, a progression of a type 3 MNV shaft from the deep capillary plexus towards the RPE without exudation. So we can detect very early type 3 in absence of exudation. We can follow their growth from the deep capillary plexus towards the RPE. And now we know that we need this contact with the RPE and eventually with the sub-RPE space in order to develop exudation. And thanks to all this information, we were investigating what happens in the fellow eye of a patient with early diagnosis of exudative type 3. And then this takes around 9 months. Actually, when we have an nascent type 3, it takes around 9 months to develop exudation. But virtually all cases with non-exudative type 3 will develop exudation. This again in around 9 months. Another important information is that type 3 is typically characterized to develop in eyes with GA. And a long time ago, we proposed that nascent GA could be not only a sign of development of geographic atrophy, but also of development of type 3 MNV. And I will show in this case how a drusen that then develops nascent GA, over time, we can detect a very early type 3, and then following like we do with nascent type 3, the descent towards the RP with the very initial exudation. So nascent GA is a risk factor for development of exudative type 3. So we should follow nascent GA not only as a high-risk lesion for development of GA, but also as a high-risk lesion for development of type 3, because otherwise then we will find cases with such progression with exudative type 3. So if we look at nascent GA over time, so the important information is that once we have nascent GA, again, around 9 months it takes for development of exudative type 3. So once we have a nascent GA, we have to follow these patients very strictly in the subsequent 9 months, because in this 9 months, patient may develop type 3 and then exudation. So in conclusion, now we have important information coming from OCT and OCT angiography that may help us not only to follow patients with exudative neovascular AMD, but also to detect very early phases of non-exudative type 1 and type 3, and then following them in the most appropriate way in order to treat them quickly and get the best outcomes with anti-VEGF treatment in our patients. Thank you very much for your attention.
Thank you so much, Giuseppe. Excellent talk. And your work in type 3 is very well admired everywhere, and I think it has contributed a lot. Any questions for Giuseppe?
Yeah, I just have a small question that I'd like to ask. A great presentation, Giuseppe. On a practical sense, when we're using commercially available machines, how would we be able to differentiate the flow artifact that may be produced by pigment from an actual flow artifact? Because when you have anterior migrating RP cells, they could also result in a nascent atrophy later and not just in an RAP going into a nascent atrophy.
Right. That's a very important point, because we also detected many cases with just pigment that were showing that's kind of a PIM, but inside without fluid. So these small movements of pigment may cause a misdiagnosis for type 3. Well, I think that this is not much important in the clinical practice, because what we have to look into in our patients is the progression over time of this flow that may be real flow, so true flow, or a false flow. And if over time we see that this flow is descending towards the RPE rather than ascending towards the more inner layers of the retina. So this could be a sign of a nascent type 3. And since this is an high risk for the next 9 months, more or less, from initial diagnosis of flow inside the retina, so we know that in this less than a year, we have to follow more strictly our patients. And again, if we see that the flow is descending towards the RP, that's a good surrogate for diagnosis of nascent type 3.
Thank you.
Giuseppe, can I ask you a question? Because it's always an excellent presentation. I was wondering, as time has evolved, how good have you become, or how possible is it to predict the course for those non-exudative type 1s, in terms of you clearly distinguish these two phenotypes of ones that remain quiescent versus ones that are just subclinical on the path towards exudation. Do you have OCTA clues now, or structural OCT clues, aside from just, I know that you and Eric have shown maybe just if there's an increase in axial height or something, then that's going to happen. But just when the first time you see the person, the patient just been referred to you, can you make any guess?
No, you know what? From the original description, we suggested to follow strictly these patients from the first diagnosis over the next 6 months. Strictly means every 2 months. So I don't think it's needed more than this. So every 2 months, and if you see some progression in the overall size, and from the beginning you have information about high density of vessels inside the type 1 MNV on OCT angiography, this may suggest that the exudation may develop quite soon. So this is the way we are managing patients. I can tell you even more than this, because we are going to submit this paper. We have cases, so we don't treat cases with non-exudative or quiescent MNVs, and we have many more than fluorosimphals that are keeping dry without any treatment. And we have collected cases that develop some exudation over time, and then spontaneously this exudation disappear. So those cases that are staying without exudation for a while may develop some exudation over time, but since they are much more arterialized than the other type that are just the initial step of type 1 MNB, then they may even I mean, the fluid that the small fluid that they will develop may regress spontaneously. So no urge to treat patients with those cases that are not exudative for a while, even if they develop some fluid. Of course, if the fluid is a lot, things is completely different.
Can I?
Please go ahead. Go ahead.
Okay.
Stella, last question. Yeah.
Thank you. So Giuseppe, thank you for this excellent presentation. One question, do you have any hint for the clinicians when they look at the OCT and you see nascent GA, if this will progress towards the GA, geographic atrophy, or towards the MNV type 3? Is there anything that the clinicians we should look, let's say, pay attention to?
Unfortunately not. In our serious cases that from nascent GA developed in nascent type 3 were around 20%. So it's quite a large number. Unfortunately, they have also, I mean, nascent GA also typically develops hyperreflective foci, so pigments that may be misdiagnosed as a type 3 or an nascent type 3. So I think that the only way is following strictly patients, and the next, again, in the next 9-12 months.
Jay, before we go, you said you use it very rarely ICG. So what would be your indication for an ICG or fluorescence? I mean,
no, we use a lot ICG, I can tell you. And this because in ours, mainly for research. But I can tell you that in clinical practice, in general, we use ICG when after starting treatment, we don't see any good response, considering what we are expecting for that specific phenotype. So in that case, we need both FA and ICG, a combination of non-invasive and invasive angiography to find something like polyps that we are missing or inflammatory state that may be causing the suboptimal response to anti-VEGF and so on. So only cases that are not responding properly to anti-VEGF treatment and in which you did not perform dye angiography, then probably in clinical practice deserve dye angiography.
All right. I think thank you so much. We need to move on. Thank you so much, Giuseppe. We will get going. We will move to our next talk to Stella. We'll be talking about diabetic retinopathy updates. Thanks, Stella.
Thank you, Jay. Thank you, Vas, for the kind invitation. Okay, let me see. Just a second. Okay, can you see the presentation?
yes, yes.
Okay. So I will be talking about the update on imaging in diabetic retinopathy and diabetic macular edema. So definitely the imaging, especially the non-invasive imaging, let's say of the macula, and then the ultraviolet field imaging of the retina, both non-invasive and invasive, is something that I think will revolutionize the staging of the diabetic retinopathy. Because definitely we are able to capture earlier stages of the disease and also to evaluate better the far periphery of the retina. So, for example, if we think of the elementary clinical lesions of diabetic retinopathy, such as the microaneurysms, now we have definitely several imaging modalities with which we can evaluate them. So not only the color fundus photos that we were used in the past, or let's say fluorescent angiography, but also we have the OCT and the OCTA.
And definitely, these two non-invasive imaging modalities are something that help us to evaluate which type of microaneurysms we have. So if we have the microaneurysms that are hyperreflective completely and that are associated with the flow that we can see on OCTA and with the cyst, so these are those leaking microaneurysms, or for example, we can have the microaneurysms that have hyperreflectivity in the inner side of them, and these are not associated with the flow, but actually these are more associated with the ischemia. And for example, if we think on the ultrawide field imaging, we know that we can see with the ultrawide field imaging, we can see 82% of the retina, and we can see this far periphery where a lot of the lesions can be seen on color fundus photo and also on fluorescein angiography. Here you can see how it goes well beyond the 7 standard TDRS fields. And why this is important? It is important because, for example, these peripheral retinal lesions, especially peripheral retinal ischemia, is associated with these lesions, and it is also associated with higher progression of diabetic retinopathy, especially over, for example, the 4 years time. And ultrawide field, for example, fluorescein angiography was proposed for future staging systems of diabetic retinopathy and also for clinical care to more accurately determine the prognosis of non-proliferative diabetic retinopathy. If we think of the evaluation of the macula, definitely the OCT is now the gold standard, and also the OCTA associated with OCT can give us a lot of information. We know that in this way we can objectively evaluate both the neuronal damage of the retina and also the microvascular damage of the retina. So OCT definitely is mostly used for the evaluation of central retinal thickness, and that is the parameter that we use mostly when we want to decide the treatment, how to proceed with the treatment, if to stop the treatment or go on. But we know that that is actually not the parameter that is mostly correlated with visual acuity, and that diabetic macular edema and diabetic retinopathy is by far more complex condition because there is a complex interplay of microvascular modifications and also neuronal injury and also retinal inflammation that finally lead to the impaired outflow, and all of these different mechanisms can impact visual function. So definitely we can evaluate different parameters inside the macula on OCT that goes far beyond the pure evaluation of central retinal thickness. So here, for example, if you see this image, you can see that there are hyperreflective retinal spots of foci, specific cysts in the retina, subfoveal retinal detachment. We can evaluate the disorganization of the inner retinal layers, but also the integrity of the external retina, so the external limiting membrane and photoreceptor integrity. So, for example, the drill is something that has been widely studied recently, and because this parameter has shown to be predictive of visual acuity response to treatment in center involving diabetic macular edema. The signs of neurodegeneration and neuroinflammation, so the drill and also these hyperreflective foci, is something that probably is correlated to poorer functional outcome in these patients. And actually, in this large study that was performed in the Hong Kong clinic, the authors evaluated the baseline drill, hyperreflective foci, and disruption also of the external retinal layers, so external limiting membrane and ellipsoid zone of the photoreceptors, and they found that these parameters in patients with DME undergoing anti-VEGF treatment were those correlated towards visual acuity outcome. So the hyperreflective foci, for example, is something that has been studied by several groups worldwide, and all different groups have shown that this parameter, as a sign of retinal inflammation, like aggregates of microglial cells, is something that decreases with the treatment. However, it is still not completely clear whether the hyperreflective foci can predict the treatment outcome in patients with DME. If we think of the OCT, we know that we can evaluate different parameters in the macula, or if we use more wide field imaging, also in the mid-periphery. But definitely what we evaluate mostly are the characteristics of the foveal avascular zone in diabetic patients. And here, it is not just the area of the FAZ, but definitely what is the form of FAZ. So what are the contours, or if there is the loss of circularity. Besides that, we can also evaluate the parameters of perfusion, especially the vessel density and perfusion density. And all of these parameters have been shown to be very important for the evaluation of so-called macular ischemia. And actually, in this recent paper, just recently accepted, we found that, for example, in diabetic patients, the ischemia that can be found on ultrawide field imaging with fluorescent angiography can be very well correlated with the OCTA findings in the macula, especially with the perfusion density, vessel density, and fractal dimension. However, the FAZ parameters did not show any significant correlation with the non-perfusion areas or non-perfusion index outside the central macular area. So, as I said before, all these changes, alterations in the macula, so presence of ischemia, presence of drill disorganization, and presence also of macular edema can lead to the functional impairment. In fact, there are several works published recently that evaluated the correlation between the retinal sensitivity and the ischemia as evaluated with the OCT angiography, and found reduced retinal sensitivity with the increased ischemia in the macula. And also major decrease in visual acuity was found if there was the presence of drill, and also there was the interruption of the ellipsoid zone of the photoreceptors. And here, for example, if you see this case, you can very well see how in areas of macular ischemia or reduced flow that you can see on OCTA, there is a decrease of retinal sensitivity when evaluated with microperimetry. Another important topic is the evaluation of the ischemia in the mid-periphery with the OCTA, and also the difference that you can see in the evaluation of the new vessels in proliferative diabetic retinopathy and the IRMA. It is something I think very interesting in everyday clinical practice in order to avoid, for example, fluorescent angiography, which is invasive imaging. Obviously, with the new algorithms in AI and deep learning models, now, for example, the retinal fluid can be automatically evaluated, and in this way, we can see the effect of the treatment. The DL models can also detect different OCT patterns, for example, cystoid, subfoveal and retinal detachment, or the spongiform one. And this is something also very interesting, a recent paper where the artificial intelligence estimated the visual acuity of the patients just from the fundus color photos. Here, we need to say that the standard error was approximately 9.6 letters ETDRS, so there was a possibility to make the error in approximately 2 lines of the ETDRS, but definitely this is something I would say, very important. And not just the photos of the retina, but also the external eye photographs, if then matched with all the clinical data of the patients, can be used for the development of multimodal AI solution that can capture the complexity of human health and disease. And in this way, they can create that is called human digital. So this is just to conclude. I have shown briefly some of the updates in the imaging of diabetic retinopathy. Definitely, we have a lot of new data that need further, especially longitudinal studies and multicentric studies, and all these new parameters would need to be validated in order to become validated biomarkers or surrogate endpoints. And that is something I think very important for the novel staging of diabetic retinal disease and also for the management of our patients. And with this, I have finished. Thank you.
Thank you so much, Stella. This was really stunning talk and very, very informative. I really appreciate that you could summarize so much in 10 minutes. That's amazing. Any questions for Stella?
Yeah, I was very interesting talk, Stella, and I found your one or two points. One, leaking microaneurysms. You know, from old days onwards, the classic teaching of doing only laser to the leaking aneurysms, which from the good old fluorescent angiographic days. Now with multimodal imaging, good to see coming back to targeting the, especially now we have these concepts of telcaps being a resistant variant of these leaking microaneurysms, which are larger in size. And I think Dr. Unni and all also have looked into this telcaps, which is probably an exaggerated variant of what you're talking about, leaking microaneurysms. I have a question for you. That is, you're talking about the peripheral lesions. Peripheral lesions on ultra wide field, that is equator or beyond, and correlating that to the progression of retinopathy as well as macular ischemia. Sounds very interesting because it goes against the classic teaching that unlike the retinal vein occlusions, diabetic retinopathy, it is more confined to the post-equatorial region. Now we are going what percentage of patients do we see these pre-equatorial ischemia, and what are the lesions that we look for? You mentioned angio ischemia. Do we look at hemorrhages? Do we look at sclerosed vessels? What are these peripheral lesions associated? One thing, and how do we really have a correlation to the progression as well as macular ischemia?
Okay, no, thank you for this question. So definitely with the we always knew that diabetic retinopathy is, let's say, a diffuse disease of the retina. So it can have different phenotypes, more central, let's say, phenotypes and more peripheric phenotypes. Currently, fortunately, with the ultraviolet field imaging, we are able to see all these peripheral lesions, and we call them PPL, predominantly peripheral lesions, when more than 50% of the lesions that we evaluate on the ultraviolet field imaging is located, let's say, outside the 7 standard ETDRS fields. So depending on the imaging modality that you use, you will evaluate different lesions, let's say. For color fundus photos, it will be hemorrhages, usually. These are hemorrhages or microaneurysms, but let's say hemorrhages. For the fluorescein angiography, there can also be like hemorrhages, but it is the ischemia that is mostly evaluated, especially this ischemic index. And it has been seen from the studies from the DRCRNet and also protocol AA that actually it is the ischemia that is evaluated on fluorescein angiography that is the parameter mostly correlated with the progression of the disease, even more than these hemorrhages on fundus color photos.
Great. Thank you so much, Stella. I'm sorry that we can't have any further questions. Thank you so much, Stella. And now we will move on to our next talk by Ramesh. Ramesh is going to talk about vascular occlusion. Ramesh, please take it away.
Yeah, at the outset, thanks, Jay and Dr. Srinivas. And I'll be talking about an update on retinal vascular occlusions. And we know that the predominant arterial occlusions are the central retinal and the branch retinal and the hemiretinal occlusions, artery occlusions. And the way we differ it from the venous occlusions is the presence of opacifications in the retinal opacifications in the arterial occlusions, whereas you have predominant retinal hemorrhages, which are coming in the venous occlusions. Now, when you look at this clinical photograph, what we see is that we have retinal opacification, which is present, and this patient presents to us with a very poor visual acuity with a sudden onset. And when you look at the OCT, it shows the typical findings of inner retinal thickening with outer retinal shadowing, and we make a clinical diagnosis of a central retinal artery occlusion. But can these images actually answer the questions? What is the severity of the retinal artery occlusion? What is the likely outcome which is going to be expected in this patient? And are there any other OCT features which are seen in CRAOs which we need to explore further? So when you look at this pathomechanism, so when there is a sudden occlusion of the artery or there is a slow flow in the retinal artery, there's a reduced retinal tissue perfusion, which causes an ischemic damage to the retinal cells, and that causes the retinal opacification and subsequent retinal thickening. And over a period of time, there will be reperfusion of the blood flow to the retinal tissue, which can either lead to a recovery of the retinal tissue to normal state, or it can further cause a damage due to the concept of reperfusion injury and eventually lead to resolution and thinning of the retinal tissues. So when you look at the OCT findings, which we say from the OCT, we can actually come to know whether the stage or the severity of what is the stage and the severity of the retinal artery occlusion. And you can see that in the milder forms of the occlusion, the earliest sign is not the complete inner retinal opacification, but what we get is the middle retinal opacification and the prominent middle limiting membrane sign. And as the severity of the occlusion keeps increasing or it becomes more, there is retinal thickening as well. But you can see here very clearly that the retinal layers are well visualized. The parallelism in the retinal layers is well visualized. And as the severity of the occlusion for further progresses, you can see that there is a loss of the opacification, a loss of the retinal layer stratification. So what we deciphered from this paper is that the middle retinal opacification and the prominent middle limiting membrane sign on the OCT are the earlier signs of CRAO, and they indicate a very mild form of the occlusion. So when you look at this table, you can actually grade the severity of occlusion based on the clinical findings which you see on the OCT in this paper. The other important sign which we see is the presence of an empty vessel. You can see that this is one of the retinal vessels which is not having the blood flow, and you can in the zoomed up image you can see that there is no flow which is seen on the OCT, which is another sign which is being described with the central retinal artery occlusion. The other features which can be seen is because of the reperfusion injury, where there is the reperfusion injury causes an inflammatory insult causing necrosis, apoptosis, necroapoptosis, and autophagy, and finally cell death, and eventually leads to a poor prognosis. So this paper, which we recently published, it actually speaks about the internal limiting membrane detachment, which is considered to be one of the poor prognostic signs on the OCT in patients with central retinal artery occlusion. Eventually, when you look at the resolution of the retinal opacification, you will realize that the opacification resolves last in the deep capillary plexus. This is what you can see in this particular OCT image. And further and further, it will lead to a complete inner retinal thinning and atrophy. That is primarily because of the vascular density being much more in the deep capillary plexus compared to the superficial capillary areas. Now let's look at what the fluorescein angiography offers us in patients with central retinal artery occlusion. And in this patient, where you have a central retinal artery occlusion with a patent cilioretinal artery, you can see that the flow or the filling of the retinal vein in the subsequent images from A to I actually shows that there is a filling which is happening in a retrograde pattern, where the vein is getting, the inferior retinal vein is getting filled up in a retrograde manner. Let's look at another case where on this video, you'll actually see the filling which is happening in a retrograde manner in a patient with a hemicentral or a branch retinal vein occlusion. And the reason for this is that when you don't have any alternative blood flow to the retinal capillaries, you don't get the retrograde filling. But when you have a patent cilioretinal artery, or where you have an incomplete or a subtotal central retinal artery occlusion, you will see that the filling is happening to the retinal capillaries, and there is a reverse filling which is happening in the central retinal vein. And this is the papers which we actually published, where we spoke about the retinal vessel filling in central retinal artery occlusion, where we had the filling of the retinal vein, which is happening only in cases where you have a patent cilioretinal artery, and also in cases where you have a branch or a hemicentral retinal vein occlusion in these cases. Let's talk about another fluorescein angiography finding which is being described. You can see that these multiple hypofluorescent dots which are seen in the middle phase of the angiogram, and these dots basically are because of the occlusion, there is a flow which is getting stopped. So there is accumulation of the red blood cells and rouleaux formation which happens, and these rouleaux, they subsequently stain on fluorescein angiography, giving rise to what is called as the mid-phase pinpoint hyperfluorescent spots, which is being described in a setting of an acute CRAO. And as the acute CRAO starts showing signs of chronicity, you can see that these fluorescent spots which are seen, they start to resolve. Eventually, you can also see that because of the reperfusion injury, there is an inflammatory insult which happens, which causes an inflammation of the retinal tissue and the vessels, which leads to leakage and which leads to the tissue damage and leakage. And you can see this in the figure D and E, where you can see that as the occlusion further worsens, there is fluorescein leakage which is happening, and that is associated with the cystoid edema as well. And eventually, once the chronicity of the arterial occlusion develops, there is a very poor prognosis in this patient. So this is where we think about a concept that is there any role of corticosteroids in patients with central retinal artery, even in the non-arthritic cases of central retinal artery occlusions. So this paper actually talks about the other multimodal imaging modalities like the multicolor imaging, which is quite useful in differentiating the different clinical features of the various arterial occlusions. Now let's talk about central retinal artery occlusion and OCT angiography. And this paper, which was published by our group, it spoke about that following an ACE paracentesis, there is resolution of the retinal opacification which happens, and that makes the retinal vasculature to be more easily visible or better visible following an anterior chamber paracentesis. This is another case of a hemicentral retinal artery occlusion, where you can see that because of the retinal thickening, there is a problem with the segmentation which happens, and that can lead to abnormal artifacts. And similarly, when there is a subsequent retinal thinning or atrophy, there is again artifacts which develop in OCT angiography. And therefore, retinal OCT angiography is primarily useful for detecting the level of occlusion and the severity of occlusion, but misinterpretations can happen due to improper segmentation in acute cases due to the retinal thickening, and in chronic cases due to the inner retinal atrophy. Now let's look at the venous occlusions briefly, and from the distribution of the retinal hemorrhages, actually you can come to know how severe the venous occlusions are. And if you look at these different zones, you can see the type of hemorrhages which you are seeing in venous occlusions, they change. And that is primarily because of the involvement of the deep capillary plexuses as you go further and further away from the site of the occlusion, which is in an indirect way, which tells us that more the periphery is involved, the chances of ischemic complications happening is much more, like what Dr. Stella told in her diabetic retinopathy talk. So let's look at another OCT finding which we recently published, is the presence of an hyperreflective material in the intraretinal layers as well as in the subretinal layers, which is associated with a poor prognostic sign in patients with acute treatment-naive BRVOs. Let's look at the OCT angiography, and you can see on this OCT image, you can see that there is a total disorganization of the retinal layers. And when we look at the OCT angiography, there is a significant dropout of the capillary plexuses in both the superficial and the deeper slabs. So in retinal vein occlusions, it's not very useful in acute cases. OCT angiography is not very useful in acute cases. It's primarily due to the excessive retinal hemorrhages and the macular edema, which leads to an abnormal segmentation. And it's useful in chronic cases, basically to pick up macular ischemia and also to pick up the new vessels. Lastly, we need to talk about the central retinal vein occlusion, where you have this, which is associated with a transient cilioretinal vein occlusion. And this happens basically because of the pressure differences in the capillaries, and the cilioretinal artery occlusion, which you have, is basically a transient phenomenon, and it recovers over time. So in summary, to conclude, I can say that the different retinal imaging modalities performed at the correct time or at the appropriate time, they help in providing useful information which can be of prognostic values in eyes with retinal vascular occlusions. Thank you.
Thank you so much, Ramesh. That was really a very good comprehensive discussion on vascular occlusion, and I believe you have published a lot on this area. Congratulations. Any questions for Ramesh? Just one question.
Ramesh, to your point that inflammation and any role of steroids, the only is young patients with CRAO without, they usually won't have the cardiovascular emboli or anything. We have actually published that even in children who have everything normal, cardiovascular thing, it is drastically improved with systemic steroids. Actually, that's the only indication I think currently improving drastically, because it may be inflammatory or spasm that is causing that CRAO. That's the only short comment from my side.
Great. Thank you. Thank you so much, Ramesh. And now I think we have 3 more talks left. I will quickly get started with my topic on central serous. I think that we are able to cover quite a bit. So I'll try to cut short as much as possible so we have a little bit time left. Okay, so are you able to see my slides? Yeah.
Yes.
So let's talk about what is going on in central serous. I have tried to cover a little bit more what we are using in the clinical practice as well as what we are doing in the future direction. So these are my financial disclosure. None of them are relevant to this presentation. So as we all have been evolving along with the imaging, where we started with ICG, that now we have wide field ICG. And then we also have now swept source OCT, where we are able to talk more about pachychoroid. Let's start with on-fast OCT, which has become almost my most favorite imaging modality, considering that we can see the choroidal vessels so well. But what do we see on the choroid? Before we understand what is going on with the pachychoroid spectrum, we need to understand how does the vortex veins look. And I usually refer to this paper, which clearly defines about variation of vortex veins in the normal healthy population, but I'll be focused pretty much on the pachychoroid. And here you can see that we are not only losing the watershed zone, which should be somewhere in the middle of the horizontal meridian. In these eyes with pachychoroid, we lose watershed zone as well as these pachy vessels. Here you can see that how they are able to cross the horizontal meridian, and they are much more dilated, as well as there is a dilation of ampulla as well. And you are able to appreciate the vortex vein anastomosis, as you can see on the red circle. Along with that, you are able to appreciate the similar area is also shown as a presence of choroidal neovascular membrane. And look at the ICG in the figure H, where you can see the dilated choroidal vessel right in the foveal area. In addition to this, you will be seeing these choroidal vessels, which are much more dilated towards the peripapillary zone, as you can see here. And not only that, they are also crossing the midline. And moving on to the next example, where you can see these dilated ampulla right at the central area. And believe me, you are able to see these choroidal vessels so well on fast OCT. We use these plex elite images, which can be you almost use as a replacement for ICG, particularly for the choroidal vessels, as we can see here. So in summary, for the pachychoroid spectrum, we see loss of watershed zone. There is a narrowing towards the watershed zone, along with dilation as well as dilation of the ampulla. And these vortex vein anastomosis are much more commonly seen in eyes with pachychoroid spectrum, particularly in the peripapillary area. Using Giuseppe's classification for choroidal vessels, we also looked into various patterns of choroidal vascularity in these eyes, and we found that the reticular pattern was more common in CSR eyes compared to the herringbone, which was more common in fellow eyes. Let's move on to OCT angio. I understand that OCT angio has been around for quite some time, but with the evolving technology, we are also understanding much more the clinical use of this technique in our CSC patients. I'll be just showing some of the example of CSR cases. Here you can see that how do we actually look at this flat irregular PED, which is seen clearly on the structural OCT, as you can see here. The top image, which is shows a flat irregular PED, which is hyperreflective in nature, but the vertical scan shows the bottom image shows empty or a hyperreflective FVPED. And here you can clearly see that the one which has a hyperreflectivity within the PED, it clearly corresponds with the CNV, which is harbored into this PED. And if you look at the hyperreflective area, you will be able to see that is actually corresponding to the cirrus PED. How about using a CNV detection? We all have been using OCT angio, and this is a fine example of choroidal neovascular membrane clearly seen in a patient with CSC. How about fellow eyes? And this is one of our very interesting paper which we published a couple of years ago, where we showed that the fellow eyes also were having these flat PEDs, which also had choroidal neovascular membrane within them. How about cystoid degeneration in patients with CSC? This is not uncommon to see the CME in these cases, and we found out that many of these patients had CNV, which is why there was a persistent leakage. And as soon as we see CNV on the OCT angio, we should be treating these patients with cystoid degenerative changes in CSC with anti-VEGF therapy. This is another example clearly showing that. How about wide field ICG? Now it is becoming a routine to get wide field ICG in our CSC patients. We understand that now we are able to see these asymmetric vortex veins, which are more commonly seen in these eyes, though they are present also in healthy eyes, but they are much more commonly seen in CSC eyes. We also published the concept of venous overload choroidopathy along with Dr. Rick Spade, where we showed that these vortices are pretty much dilated in the periphery, and there could be a overload choroidopathy, which is contributory to the pachychoroid spectrum. And here on a wide field ICG, you are able to appreciate the vortex vein anastomosis, which we were discussing earlier using structural en face OCT. This is one more example where we can see that there are multiple intervortex vein anastomosis, which is not uncommon in patients with CSC. Rick Spade also published the concept of bulbosity and tortuosity. This is an example which we can clearly see on ICG, as you can look at the arrow. Along with, I would say that we are able to see these changes even on the structural en face, but we had to start looking into these findings with patients with CSC. Hideki Koizumi from Japan has published 2 papers talking about scleral thickening. They have been talking about anterior sclera, where they reported that eyes with pachychoroid tend to have a much more thicker sclera, which is anteriorly, which is corresponding probably with the posterior one, which was also reported with using high-resolution B-scan by Rick Spade, which showed that there was an increase in posterior as well as equatorial sclera in eyes with CSC. Let's move on to the choroidal analysis, which is primarily my area of interest. I'm sure that you all are aware about the concept of central choroidal vascularity indices, which we have been using, and now we are able to produce the CVI map. And I'm sure that many of you have seen this paper in IOS, and now we have taken the CVI map into the eyes with CSC, where we tried to look into the fellow eyes as well as CSC, and we found that there is certainly an increasing CVI in eyes with CSC. But not only that, we tried to correlate with the area of leakage on simultaneous FA, but we found that the CVI was much more a generalized increase, not just focal, which makes a sense that where we are able to do a PDT in a much more generalized area, which also responds really well. How about choroidal hyperreflective dots? We reported that there are increase in choroidal hyperreflective dots in eyes with CSC, which also could be present in eyes with, which are healthy eyes, but this was much more significant in eyes with CSC. This is something which we are working now, and this is a very interesting concept of talking about choroidal contour mapping. This is some of the examples from our software which we have created, where we are able to segment out the inner and the outer boundaries of the choroid, and where you can actually see the choroidal surfaces, and we can now do multiple quantitative measurements onto these surfaces. And here you can see that this is an inner surface. And now we are able to measure the radius of curvature, as well as the various measurements of curvature, considering P max and P mean. I'll just quickly go into the details with one example. This is an example comparing an AMD healthy and CSC, where we can clearly see that how the contour is different and in CSC eyes compared to the AMD. And this paper is under revision with ophthalmology science. And these are some of the quantitative comparison which clearly differentiates these three groups, and which talks about the differences in the radius of curvature among these three groups. We are yet to learn how to utilize these more into the clinical sense. The last part is the 3D choroidal imaging, which has been my goal for last couple of years. And now we are at a stage that where we can actually do these 3D choroidal vessel segmentation from a patient, which it was imaged on Plex Elite. And now if you want, you can just pick one of these vessels and look at these focal constriction. This is a patient with CSC, where we can actually quantify multiple measurements and look at these focal constrictions. And now we are aiming to quantify the choroidal vascularity again in the 3D, which is much more accurate. In addition to this, we are looking into vessel volume, tortuosity indices, and void volumes. We are also working in developing the laser Doppler holography, which is a non-invasive imaging for retinal vessels as well as choroidal vessels. And here you can see that these vasculature, these imaging is able to calculate the velocity measurements along with systolic as well as diastolic changes. And this is one of the examples from our patient where we are able to generate wide field LDH images focused on retina as well as choroid. And now we are looking into the quantitative measurements of these vasculature into our disease patients. And one of the unique things which I'm most excited about, that this is the only imaging modality which can differentiate choroidal arteries from choroidal veins. And this would be very applicable in choroidal diseases. With this, I would just conclude saying that structural on-fast OCT is becoming my imaging of choice in patients with CSC or pachychoroid. OCTA has a great role. Nowadays, we have learned a lot about OCTA. And wide field FAICG certainly gives us a lot of understanding about peripheral vortices, and we are looking into choroidal contour mapping as well as 3D imaging. With this, I would like to acknowledge the collaborators and the funding agencies. This is our team at Choroidal Analysis Research, and thank you so much for your attention.
So question now for Jay. Jay, can I ask you a question? You know, one of the very interesting things for me about central serous is obviously when you have a patient complicated with MNV, there can still be multiple fluid mechanisms. You can have non-exudative MNV in the context of central serous with fluid from the central serous mechanism and not the MNV. Do you have clues for how you can differentiate that aside from, or do you just have to give an anti-VEGF injection and that's how you judge ultimately what the driver fluid is in a particular case?
I think that's a very tricky question. And there was one more interesting case, which I didn't include here, is that a patient with established CNV who was treated and he was doing well. And all of a sudden, one day he came with a large bump with subretinal fluid. And I was pretty sure that the height of the subretinal fluid was so much that I believed that this was not because of CNV, but because of CSR leak. And we got his ICG done, and we did see a focal leak. And then I did not treat that patient with anti-VEGF, but I treated him with focal laser, and he did really well. But I understand that I myself have a couple of cases where I'm still struggling with differentiating between CNV and the CSC mechanism fluid. But one thing I have started doing is that when I see a situation like this, where I have a diffuse leakage on ICG as well as there is a presence of CNV, in these patients, I do a combination therapy with PDT and anti-VEGF. So I'm hoping to hit both the mechanisms and then follow up these cases with probably with anti-VEGF. May not be me just try some cocktail.
Sometimes you have to do an empiric therapy. Yeah. Any other questions?
I think for the paucity of time, I think we go ahead. A lot of things to discuss, but I think.
All right, Jay, we can go on to, you can introduce the next.
Thank you so much. So I believe Dr. Bhavankar is not able to attend the meeting, so we will be playing his recorded video. The IT team, yeah, perfect. Thank you.
I'm resharing just.
Sunil?
I'm reshare.
Oh, okay, fine. We are waiting.
Good evening, friends. Thank you, IOC, for this opportunity. I would be speaking on wide field imaging, and we will share with you the case series where you will understand the importance of wide field imaging and why we call it fixing the missing link. Well, today we are having a gamut of available options in the form of wide field imaging. We have the Mirante by the NIDE, where we get in a single field of view of about 163 degrees compared to upward, which is about 200 degrees. And with a Polage, you can reach almost up to 220 degrees with this. So let's see through the application of wide field OCT. In a standard OCT, you get a beam width of about 9 to 12 millimeter. In this particular machine, you have a dimension of about 16 millimeter, and that allows you a simultaneous viewing of a extramacular pathology along with the disc or with the macula, or in a peripheral lesion, you can study bigger peripheral lesions more in a detail. Now, these are some of the books, examples from the books which we have taken over, but I will show with you some of the cases. So this is a 80 years female who complained of decreased vision. This is a fundus photograph where you see some mass lesion. This is a peripheral PCV, and this is the more magnified view of it. And when we do an OCT, you not only see in this particular frame the fluid over here, but the lesion also is covered up. And this subsequently was treated with anti-VEGF in the form of brolucizumab, and sequential OCTs, you can monitor actually the decreasing trend of the PCV lesions. Another patient who was diagnosed to have normal OCT probably feels some blunting of the fovea in the left eye. But when we did a wide field OCT through the disc, you can note the peripapillary schisis. Well, coming to the utility of wide field angiographies and photographies in diabetic retinopathy, well, you can actually look at the peripheral non-perfusion, which you can quantify them, and then you can think about doing a targeted laser therapy. Now, this is one particular patient who has done a color photo and a banded angiography elsewhere, which gives you hardly any information. You can see that there is hemorrhage and hardly few dropout areas and in NVD. When we did a wide field angiography, you can see that there is such such a significant dropout in the periphery as well, with very scattered laser marks are seen. And in a wide field angiography, you can see even a peripheral part. So just paravascular dropout, a significant dropout over here. You can see some new vessels over here. So this needed an additional fill-in laser, much more significant compared to the standard FFA, where you got hardly any information. You can see the magnitude of the ischemic dropout, and accordingly you can do the targeted laser. In a retinal vein occlusion, again you can quantify the areas of capillary non-perfusion. Now this is a color fundus photograph from the patient's file. You can hardly see some dropout over here, but when we did at our center a wide field angiography, you can note that there is a distorted FAZ. The ischemia is not only here but quite peripherally. So we needed to do a sectorial laser much more than what we could get an information from a standard fundus fluorescein angiogram. Now, this is another patient. Patient was diagnosed to have macular edema, diabetic patient, and was advised anti-VEGF. When we did a wide field OCT, we could realize that the sciatic cavities extended much more beyond, and so our diagnosis was no longer macular edema, but it was a case of a schisis. When we looked at the peripheral fundus and we did an angiography for this particular patient, we had something different which was added. So it was not a diabetic retinopathy, but it was a peripheral vascular telangiectasia in the periphery leading to macular edema in a case of a retinoschisis. This was a patient who was diagnosed to have partial retinal detachment and was advised vitreous surgery elsewhere. But when we looked at the fundus photograph, we thought we are seeing some fibrous tissue over here in the extreme periphery. We looked at the other eye, which was attached, asymptomatic. Again, we saw a fibrous tissue in the extreme periphery. And when we did a wide field angiography, you can see the FEVR. So our diagnosis changed. So important in this particular case of a wide field imaging was that we picked up the lesion in the better eye, which was asymptomatic. We treated that eye with laser, and of course that was followed by surgery in the left eye, which was symptomatic. Another case, 48 years old male who was hypertensive and having a dyslipidemia, complained of decreased vision, diagnosed as having rod spots in the both eyes elsewhere. We did a wide field angiography and we could see the shutdown in the extreme periphery. So this is 65 years old male who was diagnosed to have epiretinal membrane in right eye with full thickness macular hole in the left eye and was advised surgery in the left eye. When we do wide field angiography, you can see multiple sclerosed vessels in the periphery in both the eyes. Yes, of course. And when we do a wide field angiography, you can almost see like an half zone disease type of a picture on an angiogram with total shutdown in the periphery, even in the right eye. So this particular patient, in fact, when we later investigated, he had a bilateral oculocarotid disease. Of course, we did the lasers and treated him with anti-VEGF, but you can see the difference what you can note on a wide field angiogram. Well, this 25 years female was diagnosed to have Eales disease with combined retinal detachment in right eye and was advised vitreous surgery. So this is the picture. Yes, of course, it has a proliferative vascular retinopathy with a combined retinal detachment. But when we looked at the fundus photograph of a wide field photograph, we thought we are seeing something called pruning of the vessels in the extreme periphery. And we did an angiogram for the better eye, and this was later on established to have a Takayasu's disease. So we treated this better eye, which was asymptomatic, all courtesy wide field angiography, which we could pick up a lesion and treated this laser and prevented the disaster, which was imminent even in the left eye. Of course, we operated the right eye for vitreous surgery later. This patient, this girl had a right eye thicycle following vitreoretinal surgery, and the family history was significant. Father had an operated case of glomus jugulare, and grandfather had vague history of having been operated for brain tumor. And look at this fundus photograph. It looks clinically almost normal, but we had some gut instinct. We thought we will do a wide field angiography for this particular girl, and you can see multiple angiomas in the periphery. Yes, this is what it helped us out. We could pick up a lesions, angiomas. We treated him with a laser and triple freeze cryotherapy, and this post-treatment follow-up. Father was asymptomatic. We decided to do wide field angiography for this father, and again we could pick up angiomas in his eyes. Also, similarly, we did for asymptomatic brother who had multiple angiomas, similarly, which got treated. The importance in such cases of VHL is not necessarily angiography once done and treated. It needs yearly wide field angiography to be done, as we did it in her brother, where we could pick up some new lesions and some older recurrent lesions. Now, this is a 1-month-old premature baby who was diagnosed to have ROP. We did it in a flying baby position, this particular baby. Color photos photograph. Well, this was a case of retinoblastomas with multiple seedlings in the and the tumor in the retina, which we could see. Well, this young girl presented to us with decreased vision. This is a classic case of metastasis as well as rod spots as well as infiltrations, which is a triad of leukemia. We can see it in a single frame in a wide field photograph. Well, this 16-year-old male had a blunt trauma from ball and was diagnosed to have Berlin's edema elsewhere. Of course, there was an edema at the macula, but when we did a wide field photograph for this particular patient, we could see an horseshoe tear in the extreme periphery. And this photograph helped us in convincing this reluctant patient to undergo laser because he was not ready to trust us till we demonstrated him with the help of wide field photograph. This 36-year-old male was diagnosed to have central serous retinopathy, and when we did a wide field photograph for him, you can see it was a fluid which was creeping because of a subclinical retinal detachment. In this beautiful photograph, you not only see a lattice lesion with a horseshoe tear at the edge of the lattice with a subclinical retinal detachment, changing our diagnosis and management thereby. Wide field imaging, though not a true color imaging, can help you in fixing the missing link, at least in peripheral vascular disorders, tumors involving the peripheral retina. And these are some of the contributions of ours because of wide field imaging, which we have done. So thank you once more.
Great. Dr. Bhavan Kule has just landed at the airport, but he may not be able to answer any of our questions. So we will move on to our last talk, and we really kept the best for the end. Rosa is going to talk about advances in posterior segment imaging. Rosa, please take it away.
Thank you, Jay, and thank you, Bas, for the kind invitation. It's a great pleasure to be here with such a great group of specialists in retinal imaging. And I will try to keep the timing talking about updates on retinal imaging. And I will start just saying that every success story is a tale of constant adaptation, revision, and change. And this sentence is really what it's been happening in the retina field, because we should be feeling really proud and really lucky, because we have been living a revolution in the way we treat and we diagnose the patients, as we have seen with the last talks, especially because of the OCT, but also with the developments in drugs for retinal diseases. The current situation is that we have a lot of developments in imaging that allowed us to increase the field of view, as we have seen in many talks, but also in the last talk. We have faster acquisition, so we can make this faster field of view, but also we can work efficiently in our busy clinics. And we have also better image quality, increasing resolution. But this is sometimes a problem because we have larger and larger files, and this data burden, it's a problem, and we should really start looking at other ways to analyze the data, probably with AI solutions, but also to establish new ways of data management in our databases. And the third point that we have in our current situation is that we have now new drugs that last longer. And also we have probably devices that could be implanted in the eye, and also that the way we treat patients, it's going to be changing. So we need alternative solutions for these patients. I'm going to talk a little bit about ultra wide field as a summary, how we can increase resolution, also how we can improve analysis, this way of alternative monitoring solutions, and I will just put some highlights on new imaging tools.
Regarding wide field, we have been seeing in every talk nice imaging. We have color fundus imaging, we have dye-based angiography, and we have, of course, OCT and OCTA, which is really useful. We can also have just structural OCT. We can perform large scans of OCT, but also we can perform peripheral OCT, which is really useful sometimes for surgery or for peripheral tears. But nowadays, we can also increase the depth of the imaging, so we can have these myopic eyes with big staphylomas fitting into the window, and we can see the shape of the staphyloma better. But I will highlight, as Jay say, I think fast structural OCT is really useful, especially in the spectrum of the pachychoroid diseases and central serous, because it allowed us to see in a non-invasive way easily the choroidal vessels. So this is just a summary of all the uses of this ultra wide field imaging, but I just wanted to highlight how useful and how new we are now having this imaging modality. The second point will be increased resolution. We know that with adaptive optics, we can increase lateral resolution, so we can have these beautiful images of the photoreceptors in the retina in vivo. But it's really costly, so it's not really in the clinic. We can also have alternative technical solutions like visible light OCT, but it's only for research. But in this way, we can increase the axial resolution, and we can start seeing sublayers of the layers we currently name in the OCT commercially available devices. But we have also some spectral domain prototypes, like the high resolution OCT, which also increases the axial resolution from 7 to 3 micrometers optically. And we can start seeing these beautiful sublayers of the retina. And we have been learning a lot with this prototype. We can have, especially in AMD, a lot of details like early detection of drusen. We can also have early detection and better resolution of the supraretinal drusenoid deposits and acquired vitelliform lesions. We can also have better visualization of the edges of the atrophy. So it's really a beautiful technique, and it's giving us a lot of new information in many diseases. The problem, or this additional information, is that we need to really rename or have a consensus for these new sublayers that we have been seeing, since the consensus led by Giovanni Storenghi in 2014 with a group of international experts was really based on a spectral domain and subsource OCT, and it depends on the technology. So this paper by the group of Jim Fujimoto highlighted that you can see more layers, and this is the same thing that we have been seeing as with this new prototype of increased axial resolution. So we will need consensus for the naming and labeling of these new sublayers. We will also need to have improved analysis, because we have increased number of patients, and also we have increased number of larger files. So we will need either more time to review each image, or solutions that allowed us to see better the images. Jay showed really beautiful images of 3D of the choroidal vessels, but we can also use as this, for example, for the visualization of the new vessels over the retina in this proliferative diabetic retinopathy. And we have also been seeing a lot of tools of fluid quantification that allow to really quickly review our patients undergoing anti-VEGF therapy. I think I will highlight that AI analysis, it's really useful for GA, as Dr. Bahasada highlighted, because it allows us to quickly analyze the size of the photoreceptor and RPE atrophy, the RORA area, but also to analyze the photoreceptor damage. And also, because of this increased number of patients and these long-lasting agents that we have now in our clinics, I think home monitoring and vitreal imaging clinics are now going to be really important, not only telemedicine thinking on a screening, but also for the management of these new drugs. So there are many options, not only in fundus imaging, but also in OCT, because you have been seeing that OCT is really what retina specialists we need in our clinics. And just to finish, I want to highlight some new imaging tools that I think could be important for the future. The first one is the NIRA, because I think this delay near infrared angiography, it's quite important because it could really help us to understand where the new areas of atrophy are going to be appearing. So you've seen that these areas of hypoautofluorescence corresponding to areas of GA, of geographic atrophy, correspond also to areas of hypoautofluorescence in the hypofluorescence in the NIRA. But it also, you have a lot of extensive areas of hypofluorescence in this image, suggesting that the choriocapillaris is damaged already in all these areas. The second point I want to highlight is this detection of reticular pseudodrusen by embossing of the image, led by Dr. Sada, because I thought it was really important. So what we are missing in the classifications of AMD right now is that many of the historical data we have are based on color fundus imaging, and we know color fundus imaging is not the best modality to detect a reticular pseudodrusen or subretinal drusenoid deposits. But with this technique, we can retrospectively analyze color fundus imaging and enhance the image in order to see this type of deposits that we know they are really have a lot of prognostic information. And the last thing, I'm just not citing this paper because I think it's the best, but I'm just citing a paper of optoretinography because I think functional OCT with optoretinography, I think it's going to be really in the future really useful. It's non-invasive, it's based on OCT, and it allows us, for example, to see this dark adaptation kinetics in the outer retina, and you can see that light adapted and dark adapted, we can see in vivo changes in the layers of the retina. So I think it's really interesting. So with that, I will conclude, and I'm waiting for your questions. Thank you.
Thank you so much, Rosa. That was fantastic, really new and upcoming. And I'm sure that at least this group is always excited to see what is new coming up. Any quick question for Rosa? It seems people are still awed with your presentation. So Rosa, I was just wondering that how far do you see high resolution OCT getting into our clinics?
Well, I think it's not maybe useful for any disease. For example, for diabetic macular edema, we think with the current resolution, it's enough to manage. But for AMD, specifically geographic atrophy, I think it will be really needed because it allows us to see more detail, detect earlier the changes. So I think it's going to really be useful in many diseases, also for maybe inherited retinal diseases. So all the things that have really degenerative conditions could be that. I really don't have any experience in glaucoma, but I think it could be also useful. So in those diseases where changes are really small, I think this will allow us to really have early detection. So that will be really interesting.
Perfect. Thank you. More details, more confusion. Thank you.
Yeah.
All right, I think we are already running out of time. So thank you so much, everybody. This was really a fantastic session, and I learned a lot. And I really want to thank everybody in different time zones, and have a great day ahead. And I will hand it over to Aarti for concluding remarks.
Thank you so much, Dr. Jay, for moderating this session so very well. And I would like to congratulate all the presenters for making lovely presentations and making the topic so very interesting. As I said, I'm an anterior segment surgeon and I don't fit here, but believe me, I really enjoyed it and I was sticking to my chair. I thought, let me just see what is happening. So thank you once again. And I would like to thank all our audience for making this 3 days event very successful. And we really had good number of registrations and viewers. So just a quick reminder, this is an online event, so it was a recorded event. And all the talks will be available on AIOS website. And we'll try to send the recorded link to your registered email address so that you can go and view the sessions again whenever you want. So thank you once again, everyone, and see you all next year. I hope with some more new things coming up in Retina. Thank you and good night.
Thank you. Good night.